Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator in the NICU as well as a NICU nurse. I think next week when we are meeting, I will hit my 21 years of being a NICU nurse, but welcome today for our Teach Me Tuesday. As you may know from last week's video, in January of 2025, we are doing a back to basics. And last week we talked all about assessment, and today we're going to dive more into respiratory assessment. If you've been here for a minute, you know I have talked about the most common reason a baby is admitted to the NICU, and that is respiratory distress. And you may say to yourself, oh, it's prematurity. Well, prematurity is one of them, but most of those babies are also in respiratory distress. But when you think about the vast majority of NICU admissions across the time span, it is respiratory, whether that's a late preterm infant, meconium aspiration, HIE, just having a hard time breathing, IDM babies and their surfactant production being less, all of those things. So respiratory is the backbone of a NICU nurse's assessment. So respiratory assessment is critical in the NICU because neonates rely on early interventions. So this is that whole thing about, when you get somewhere, you assess the situation quickly. And even with NRP and the idea of initiating PPV within those first 30 seconds of life, and how important that is in the baby's story, because without proper ventilation, babies are not going to do well. And so we have to use our assessment skills to really identify some changes in those breathing patterns, to know what your patient's baseline breathing pattern is, so that you can see if we're in distress, where it's a quick thing that we could fix, like a displaced ET tube, even a displaced NG tube, or if it's a disease progression, such as worsening PIE or highly memory disease or RDS, pneumonia, pneumothorax, etc. So our respiratory status is often told to us and affected in the oxygenation and the perfusion. Both of those things is what's driving the health of the baby's brain and their organs. So really knowing what normal and abnormal are is key. So let's talk about what a baseline respiratory assessment is. The normal respiratory pattern for NICU patients is 40-60 breaths per minute. And I pointed out before, and I'm going to say it again and probably multiple times, is knowing what your patient's baseline is. Many babies breathe 60 to 70, 75 times a minute. So if your baby is often breathing 65 to 70 times a minute and now they're breathing 75, that's not as concerning to me, as opposed to a baby who's typically breathing 40 times a minute and is now breathing 70 times a minute. So it's really taking in, which is also what I love about EHRs and our monitors. Look, you can go back over the time span and see what the patterns are. In electronic health records such as Epic, you can go in and see graphs of what the baby's vital statistics have been doing, and you can see what have the respiratory rates been, and really see kind of what's going on there. Even if it's your first time having the patient, you should be able to check that out. I already can tell I'm interchangeably saying your baby and your patient because your baby is the parent's baby. I'm going to work on that. So breath sounds are clear and equal. We're not hearing wheezing. We're not hearing crackles. Our chest movement should be symmetrical, rise and fall. The baby should be pink, and they should have quiet breathing with no nasal flaring or grunting. The perfect NICU baby, right? All of your patients look like this every minute of every day, right? So what is respiratory distress? So respiratory distress is when there is a problem with the exchanging of gases, whether that's getting oxygen to the baby or getting rid of carbon dioxide. And so a baby shows us that they are in distress with grunting, flaring, and retracting, right? So flaring is just literally taking this nasal passage that they have, if you think of it like a straw, and turning it into a bigger straw. It's saying, I'm not getting enough air in there. I need you to get bigger. And so I'm going to flare the end of the nostril so that more air can come in with each inhalation. All that's great temporarily, but if the baby has to do it over a long period of time, they're going to tire out. The same thing with grunting. So grunting is down here in the sounds of distress. I said it last week. I've said it probably in 5 videos over my time here on YouTube. Grunting is auto peeping. It is the baby saying, do not fully close. Don't close alveoli. Don't close. I want you to stay open, because once these alveoli collapse, as in this picture here, they're not going to reopen. So I've got to let you stay open. It's like this panic of keeping the alveoli open, and it creates that sound that's grunting. A baby can auto-peep for a period of time, but not forever, and they're going to tire out and they're going to be in more distress than they are now. Anytime you see cyanosis or mottling, tachypnea, apneic episodes. Stridor is often suggestive of that upper airway obstruction and can also be heard after an extubation. So just things to think about. Intervention, we want to address what's going on. If a baby's grunting, we want to get them on CPAP. If they are flaring, maybe they just need some high flow. If they have new retractions, maybe they need an increase in any of those modalities. So some things to watch for, we're going to dive into retractions. So the location of retractions can often tell us kind of what's going on with the respiratory tract. In the upper airways, you're going to often see suprasternal or supraclavicular retractions. If it's in the lower airways, you might see subcostal, substernal retractions. So really thinking about where it is going to help you kind of identify what's going on. But suprasternal or supraclavicular is very concerning. I mean, we are working so hard that you're going to see the pulling way up here above the sternum and above the clavicles. So the skin above the breastbone and the neck area is pulling in. So think about what's going on up here. So high is suprasternal. Intercostal is any of the skin between any of the ribs. So you can see intercostals high, medium, low. I just have one arrow here indicating kind of where it is, but intercostal is any of those spaces between the ribs. The intercostal space, right, are those muscles kind of between your ribs. So anytime you see pulling in there. Subcostal is when the skin below the rib cage, so we're getting away from the costals or your ribs, is pulling in. You're going to see that belly breathing. And then substernal is below the breastbone where it retracts with each breath. So these are some of those retractions that we're seeing. Sometimes we might say they're mild, moderate, or severe. I think that those are great words, especially for you to use from your shift to your shift, or you to pass off to someone, looking at it together and saying, hey, I was charting these as mild intercostal retractions. I just see them way down here at the bases. It seems pretty typical for a 27-weeker versus they did not have any intercostal retractions, and now I'm seeing moderate retractions. And a very important part of handoff, which we talked about a little bit last week with documentation and handoff. So when you think about crackles, so crackles are abnormal breath sounds caused by fluid in the alveoli or the airways. So those fine crackles, we're probably going to hear more often when they're having this like rubbing hair near your ear. It's usually with atelectasis. We're going to see atelectasis more than other things in our NICU. Coarse crackles can sound like that bubbling water. I think that they're harder to identify. We can hear them when they have secretions, but then they go away. But coarse crackles that kind of stick around for a period of time, I don't hear as frequently as I hear fine crackles. That's my experience. But making sure that we're using a stethoscope to really auscultate all the lung fields and trying to identify where we're hearing it. I think the side to side of hearing, what am I hearing on the right upper versus the left upper, is going to be very important when assessing your crackles. So let's talk about what you're going to hear when your baby's in a different vent mode and what you might be looking for as far as respiratory status. If your baby is on CPAP, you're still probably going to hear clear breath sounds. You might hear some bubbling or some air pressure coming in. You should see symmetrical chest rise. It should not affect what you can be able to assess if a baby's on CPAP. Same with NIMV. If the baby's on a high pressure and they're doing, some mouth breathing, or they don't have a chin strap, you might hear the pressure of the air affecting kind of what's going on with your assessment. But it should be pretty obvious when you're listening what is noise from the ventilator and what is noise from the baby. When the baby's on a ventilator, you want to be checking for that equal lung expansion and listening for air leaks, remembering that the reason we're comparing side to side is the tube could become displaced, more likely for the tube to go down into the right main stem, and so you'll have lung sounds on the right and not on the left. Obviously, if the tube became completely displaced, you may have different lung sounds, but if you are more on one side than the other. And then depending on what the ventilator mode you're on, sometimes if you are not on a synchronous mode and the baby's taking a breath and then the vent's giving them a breath, it can be hard to differentiate. So making sure you're listening for that full minute when you're doing this assessment so you can hear and see what's going on with the baby. Auscultation and high frequency ventilation are tricky. High frequency ventilation doesn't allow for this. Can I listen to their inhale? Can I listen to their exhale? Am I hearing any abnormal sounds during that inhale versus during that exhale? And so I encourage you to use an opportunity when you're exposed to either the high frequency ventilator, oscillator, or the jet to listen to kind of what those breath sounds could look like. Lung sounds are going to be muffled or absent. If anything, I think that we auscultate to listen to the heart rate, but to get a good assessment of the baby, we're more likely to look at the chest wiggle, the pulse oximetry, our blood gases, and then whether we're on a TCOM, a transcutaneous monitor, or an end-tidal, whatever it might be, to see what those changes are telling us as far as how well the baby is ventilating. If we do auscultate, especially if we're looking for something like a pneumothorax, we often are going to have to pause the ventilator to be able to listen. And so we try to limit that. Every pause in ventilation allows the alveoli to collapse and have to re-recruit the inflation. So we want to limit that as much as possible. In fact, I've worked on a unit where we really only pause the ventilator if all of the other things I just said were concerning to us. Our chest wiggle had changed, our CO2s were changing, whether on a gas or on a TCOM, and our oxygen was rising. And usually we would pause it for a provider to listen. So just keeping those things in mind so that we're not getting this de-recruitment of the progress we've made as far as inflation goes. Similar with suction, especially suctioning on some high frequency ventilators requires pausing as well. We also use suction, I think, as a crutch of kind of, hey, my respiratory status appears abnormal, so I'm going to suction and see what's going on. But really, we should watch for signs that the baby needs to be suctioned, increased risk of breathing or retractions, prolonged desaturations, visible secretions, or audible gurgling. In my opinion, if you can't see it and you can't hear it, you probably shouldn't be looking for it. So obviously, if your baby is doing poorly, right, decreased chest rise, absent breath sounds, severe bradycardia, get in there and suction. They could have a plug. But if they're just having some desaturations that they're responding well to, and we're going to see that a lot, especially if your baby has a PDA, has had any changes in their ventilator settings. So really just thinking about when we suction, we're also going in and stimulating the trachea and the bronchioles, and they produce secretions. So it's this vicious cycle of what kind of came first, the chicken or the egg. Did the secretions come first? Did my suctioning cause the secretions? So I just say this to remind you to be judicious with your suctioning and to think, can I see it? Can I feel it? Can I hear it? If those things are true and the baby seems to be negatively affected, suction. If the baby is in profound distress, suction. Otherwise, are there other interventions we could consider for what's going on with some mild desaturations? So respiratory status and neuroprotection kind of go hand in hand. Oxygenation and brain health. So when we think about needing adequate respiratory function, that's going to ensure that we're getting that oxygen delivery to our brain. It's going to prevent hypoxia. It's going to prevent hypoxemia so that we don't cause any long-term damage to their brain. So respiratory is neuroprotection. It is saying we're going to keep the baby in this nice, healthy place so that their brain can do this great growing. We want to prevent stress and injury. So I think about that with our interventions such as intubation. How can we best support the baby during that period of time? How can we best support them when we're suctioning them to make sure that we're being gentle, we're not using too much pressures? When we're giving PPV, whether that's in a recovery from delivery, in a baby having a profound episode, prior to intubation, making sure we're using the right pressures to help them. And then also, when we think about the position that the baby's in during all of these procedures, we want to help reduce the stress and overstimulation. What parts of their body can we swaddle? What pain medications can we use to help really protect those brains during these crucial interventions? When we think about proper ventilation, we've talked about gentle ventilation in our high frequency versus jet videos maybe back in May, so go back and look at those. But really avoiding hypo and hypercapnia, avoiding those carbon dioxide levels swinging, that's the thing I think that we tend to miss as like a key concept as NICU nurses is this idea of going from one extreme to another is just as detrimental as staying at an extreme. It's true for temperature, right? If your baby's really cold and then they're really hot, it's not good for them. It's true for their hematocrit. We don't want them to go from a crit of 20 to 40 after one transfusion. It's true for their blood gases. You don't want to autocorrect from a 7.0 to a 7.4. So what can we do to help slowly watch the march of their CO2 into the right direction? That's going to be that safe ventilation that's going to protect their brains. And then synchronized care. I think about this with not just cue-based cares, which we talked a lot about last week, but the idea of when is respiratory assessing the baby? When is the provider assessing the baby? When am I assessing the baby? And most importantly, when is the family going to be there? What interventions do need to be done? Maybe your baby's on a breathing treatment and that needs to get done. Maybe it's the day that we need to change the tape. How can we work together to reduce the disruption to the sleep and support our natural development that the baby's having, because that is what's going to foster their brain growth. So if we can kind of work on all these things simultaneously, we are neuroprotectors. We, as the bedside nurses, as their caregivers, are neuroprotectors. So what do we need to tell our parents, right? Our parents need to know what the baseline is. We talked about this last week of, really listening to our parents when they tell us something is different. They're the primary caregivers of their baby. They will know when something is wrong, but they need to know what the baseline is. So this is what your baby is typically breathing, right? You can see occasionally they pull these little muscles kind of down at the bottom of their ribs, but that's their baseline, your baby's baseline. If you notice that they're pulling harder, if it's moving up into their ribs, or you can see them pulling in around their neck area, not even using the word clavicles. You could say if the skin is no longer pink, if you hear them making noises, give them words to describe the changes that they are seeing. So if you see flaring, if you hear them making noise, it sounds like little grunting, if they're retracting, if their skin changes efforts. So ask them to empower them to ask those questions. My baby seems to be working harder. They look different. They sound different. This whole team is here. We're here to support you. We're here to educate you. And we all want what's best for your baby. So to recap this week's Teach Me Tuesday, just to remember that respiratory assessments in the NICU are vital. We need to monitor changes in the baby's breathing patterns. It's crucial, absolutely crucial for us to focus on each baby's individual baseline. I can't say that enough. That's why I love team nursing. I love the idea of having like a care team that primarily takes care of the baby. Obviously, listening to the parents who are there often, adapting your assessment to those different ventilation modes. Maybe you had this patient when they were on the high frequency ventilator and now they're the conventional. You need to reestablish what your and that baby's baseline are. Talk with the outgoing nurse. What were you noticing? What were you seeing? Doing these frequent checks so that we have early intervention. The early intervention is not only going to prevent respiratory complications, but also neurodevelopmental complications. And it's going to improve the outcomes for the babies and their families. So thank you for joining me for this Teach Me Tuesday in January of 2025, where we're going back to basics. I hope you enjoyed it, and please comment or let me know if you have any questions. As a reminder, you can find me on Instagram with the same handle of NICUeducator.Lisa. I am over there and here on YouTube, and I hope you have a great day, and I will see you next week.